Now, what are health systems for? Why do we spend so much time and energy? And this is exactly the question of the goals of the health system, okay? And that's what our second big question. So we already talked of the first goal, the defining goal, right? That goal is health. Now, let me just make and clarify something, because it has to do with questions that Guy and others raised. We're going to keep this at a very parsimonious and high level by asking the question of what we call in the conceptual paper with Chris Murray, we call the intrinsic goals of the health system, okay? Because you can actually come up with a pretty long list. I mean, you could say that a goal of health system is to create employment, right? And it is a big employer. And if you go back to the big recession, people say, be careful with healthcare because it's alleviating the unemployment. And by the way, that would be legitimate, okay? Of all the things that people could do, why not have them work in a hospital or something like that, right? We're gonna, however, it's very important in almost everything we do not to confuse the means and the ends, okay? And here, what we're calling intrinsic goals are the ends. These are goals that are valued in themselves, okay? They are not means to something else. They're valued in and of themselves, okay? And they meet the criterion that they can be improved, or the level of goal attainment of an intrinsic goal can happen even if other intrinsic goals don't raise. In other words, that they are not, one is not a means to the other, okay? And in that framework, we expand a little bit of the more conventional way of looking at the intrinsic goal, which is health. And we actually acknowledge that this is the defining goal. But as you will see, we try to move a little bit beyond. First, expansion. Are we only satisfied? Is the goal just to raise the average level in a population of health? Or is there something else with respect to health, in addition to raising the average level? Yes, Mary.
I'll say so long to improve individual health and to increase the lifespan too.
Right. But what about when you look, not just at, you look at an entire society and you say, if we just increase life expectancy or reduce mortality, is that enough, or would we say there's something else we would like as an intrinsic goal? Jen?
I'm sorry, I didn't see your hand.
To decrease the inequality
Right.
Between the, ends of the spectrum.
Right, or between the different groups of society. So there is a level of health. More health is better, but we introduce a distributional requirement, okay? And this sounds a little bit abstract. It's not that abstract. You can actually raise the average level of health in a society and increase inequities, okay? I mean, a lot of you came here after many years of working in the topic of health disparities, so you know this firsthand, okay? Because if you, consistently exclude the poorest, the disenfranchised, etc., you can actually raise the overall level. If you exclude minorities, you can increase the health of the majority, and the average level, the total level, will increase. But we are saying that it is, when it comes to this intrinsic goal, we're interested in the level and the distribution. This is going to be very important because when we talk about performance, we're going to be judging performance against goal attainment. So we're going to say, a system that increases average level but also increases inequalities is not a good system. It's not performing well, okay? So that's our first goal. Mm-hmm.
But then again, this would be value-laden goals. I mean, fortunately, but someone might say, no, I don't want to.
I don't care about that.
I don't want to raise the whole population.
Not someone might say. Lots of people do say, that's not my business. My business is to improve overall health. A lot of health professionals in good faith will tell you, that's not what I was trained to do. I'm going to do the most for whoever walks through my door. Now, I am aware that a lot of people never get through my door, through my office or through my hospital, but others should take care of that. That's not don't judge me on the basis of that. And that doctor or nurse might be right, but we're not judging individual performance. If we're judging system performance, then it's very hard to say that it doesn't matter how health is distributed. But I could point to political ideologies that would actually state that. And that's why in this session, in a moment, we're going to get into the question of values, because these are, of course, reflections of values. Yes?
Well, even if preventing inequality isn't your value, there are studies now that show that the level of inequality in a society affects the overall level of health. So even if it's not your value, it could still be a means to improving the overall level of health.
That is a very good point. In fact, that is true. And if you have, when you try to predict what, say, would be the expected level of health according to, say, income per capita, you can show that those that fall below the expected curve in a regression, that's due to higher levels of inequality. So there are all kinds of reasons why you could actually justify this. I mean, a big reason is that there are externalities, for example. And we're going to get into that when we talk about values. But the general point that Daniel is making is absolutely true. These do reflect value choices. Now let me ask you, if we said that's it, most frameworks will stop here, okay? Most frameworks will stop here. Now we add distribution. Okay, what then if I tell you, and so do we increase health at any cost? So for example, when the AIDS epidemic started, several countries, I won't mention names because that's not the purpose here, started people who were positive, HIV positive up. I mean, literally locking them up in whatever you want to call them, concentration camps or whatever you want to call them. Their freedom of movement was restricted. Is that okay? It's again a value question. Or is there something else? Do we sterilize people who are carriers of a genetic disorder? It will probably improve health, right? If you get rid of anyone who has genes for diabetes, you will probably reduce the incidence in a couple of generations. Is that right? Is that what we want health systems to do? These are not hypothetical examples, unfortunately. So no, so there's something else, right, that we're missing here. So we talk about a second goal, which we call responsiveness to the legitimate expectations of people. Now, people may have illegitimate expectations, or we talked about this in a previous session. But there's legitimate expectations that you will be treated with fundamental respect for other other cherished social values. That is to say that we will improve health, but in accordance to norms of professional behavior. You do no harm, you do not act, and with respect to fundamental human rights associated with the process of care, okay? And in the paper, and I'm not gonna go more because we don't have time, we talk about two dimensions of responsiveness. One we call respect for persons, respect, and the other is called client orientation. Respect for persons includes things like the respect for the dignity of people, and this is very important in health systems because we're dealing with aspects of the human body, with intimacy. We literally and figuratively undress ourselves, right, when we go to the health system. So the respect that we grant is very important. But then there's also very, very consequential things. Respect for the confidentiality of information, right? This is becoming a huge issue with genetic testing, right? Respect for the right of people to participate in decisions, them or their agents. They are minors or have limited capabilities, but the respect for the right of people to participate in decision making about their own health, right? So we don't just treat anyone against their will, right? And these are both, many of these elements of responsiveness, this first dimension called respect for people, are encoded in codes of conduct of the health professions. That's the difference between being an occupation and a profession, is that you embrace a code of conduct. You don't achieve your defining goal at any cost. But then there are also social norms, some of which are actually expressed in legislation. You cannot treat someone against their will. You cannot divulge information that's confidential, etc. Then the client orientation refers to legitimate expectations that you will be treated promptly, not be made to wait unnecessarily, that there will be basic amenities, that if you go to a hospital, it will be clean, that the food will be edible, and maybe at the end of that spectrum that you will have some choice about who actually you get to see. These are not the standards for most care in most of the world. So these are not trivial matters. Now, why do we say this is intrinsic? Because you can actually raise the level of responsiveness even if it doesn't raise the level of health. So it's not instrumental, it's not a means for better health. It turns out that if you treat people decently, for example, if you guarantee that you will respect confidentiality, more people will come to be tested for HIV, to give an example. So sometimes actually being responsive helps to do that, but you don't do it because of that. You can increase the level of responsiveness. In fact, maybe not achieving as much gain in health, like in the examples I gave of locking up people with infectious diseases or sterilizing people with carriers of a genetic trait, okay? So this is why we call responsiveness an intrinsic goal of the health system and not just instrumental. And like with health, we're interested in the overall level, but there's a distributional issue here. And this is, all studies, all kinds of studies show that women in general, I'm generalizing here, but many studies show that women are treated with less respect, with less of all of these elements of participation, etc. Minorities of all kinds, etc. So, again, it's not just the level, but the distribution of the responsiveness to the legitimate expectations. And then, again, expanding the goals, there's a third goal. Is it okay if we have a great system that improves health, it treats everyone marvelously, but then, it ruins financially a bunch of people in the society, the sickest, right? So if you're sick, you're gonna get health, you're gonna really recover your health, you're gonna be treated very nicely, but you're gonna have to sell everything, your house, you're gonna get your kids out of school and get them to work. Is that would we say that that's a good health system? Right? I think most societies reasonably, and again it's a value choice, would add fair financing, okay? Fair financing as a fundamental goal. And again, it's intrinsic, okay? It's not just a means, although if you finance things, probably health will improve. A lot of people do get enormously stressed when they can't pay their medical bills, and it badly impacts their health. But we don't do it for that. That's a great outcome if it happens. We do it because there's some sense of fairness in the way the financial burden is distributed across society. This is, by the way, only a distributional concept. There's no goal of spending a certain level. Although, we all the time say, the WHO recommends that countries spend 5% of GDP. That's nonsense. There's no intrinsic goal in spending, and more spending is not always good. In fact, there's a point where more spending is actually bad because it's crowding out the other sectors, which are determinants of health. This is what's happening in the United States. You get increases in the education budget in Massachusetts, 90% of that goes to pay insurance premiums instead of paying better salaries for teachers, etc. So you start crowding out. So there's no level goal for financing. This is very important because we very often talk about there's a level goal. This is strictly a distributional matter, which is very important. And this is central to our discussion on values. If you think, we'll get to the values in a moment, but most societies today would agree that a system that places the financial burden disproportionately on those members of that society who are sickest, who are the ones who pay more, is not fair. And therefore, fair financing becomes itself an intrinsic goal of the health system. If you put this together, the level is usually what we call the quality of the system, right? And we will talk more about that in the next session. And you know, if you take a look of quality about outcomes, you know, good care is the one that improves health the most. But Donabedian, many years ago, said that there's an interpersonal dimension of quality that has to do with the way you treat people, both the respect for persons and the client orientation. And this is the quality. And the distributional elements are the equity of the health system. This is a little bit more than our usual measures, which are centered here. We now add the distribution of responsiveness and obviously the distribution of the financial burden as a key element of equity. And then finally, the way a health system manages to achieve these goals within its resource constraints defines the efficiency of the system, okay? And this is a concept that's very much related to performance, as we will see, although performance is a little bit broader than efficiency, okay? But these terms that appear all the time are, I think you can relate them to our goals, okay? To the goal attainment. This is how well you attain your goals given your resources. One last footnote, just for clarification. People often use here, instead of responsiveness, satisfaction. And, you know, again, because this is a course on concepts, I think satisfaction is a subjective state that can be determined by many other things. Responsiveness is an attribute more of the institutional side, and we want that institutional side to be responsive to the population side. And that's why, after a lot of discussion, because, you know, everyone said, oh, you mean satisfaction. No, we do not mean satisfaction. In fact, people are very satisfied when their health improves. So if you also put satisfaction, you miss the question that responsiveness is an intrinsic goal. It's not just a means to improving health. But you know, there's lots of studies that show that if your team wins the World Cup, you know, overall levels of satisfaction with everything, including the health system, goes up. So you know, the Germans are very happy today. The satisfaction is a subjective state that's influenced by a whole host of other things. And I think it's much better to think about responsiveness of the institutional side to the legitimate expectations of the population. Because then, you know, we got issues of accountability, like we were talking before, and you can actually intervene to increase the responsiveness. So just in case that there was a question about why we talk about responsiveness, not the more common. Okay, so now this is parsimonious, so I'm coming back to the idea. This is a high level. Access is not here, right? But if you ask let's improve access. Well, why is it not here? Because you don't want access alone, right? Access is an instrumental goal. It's an instrumental goal, okay? Access to bad services would actually be counterproductive, right? You don't want access to bad services or to go to a place that's going to ruin you economically and treat you like dirt. That's not what we want. So access is very important, but it's an instrumental goal. So just so that we don't confuse the means and the end. Training doctors and nurses is very important, but it's a means to the end. We don't just want to train them so that they can make money or earn a living. It's, you know, this is the health system. This is not the economic system. The health system has that set of goals. There is, however, in a further elaboration of the WHO framework, we came to the conclusion that there is an intermediate goal, because these are like at a very high parsimonious level, only 3 goals, which has been called effective coverage. And effective, notice it's not coverage alone. Effective coverage means coverage of health services that allows you to reach the maximum attainable level of health. What do we mean by that? If today, by an intervention, you can, say, prevent a disease, if you actually have the coverage of that, let's say it's a vaccine, and you actually prevent the disease, that's effective coverage. So it's a combination of coverage alone with quality, okay? The fact that it actually achieves the attainable health gain. So it's how much of the potentially achievable health gain is actually achieved by the coverage you provide. That's effective coverage. It gets you the effect you want. And there's been a lot of literature on how to measure effective coverage, and now that there's all this discussion about universal health coverage, it's important to say it's not coverage alone. We're not interested in coverage alone, because again, if it's coverage for bad services that are gonna hurt you, you don't want that. Effective coverage is an adequate intermediate goal, because it's coverage of services that have enough quality to get the desired outcomes, okay? Particularly in terms of health improvement. Historically, there have been several principles. I mean, imagine what are the principles you would think about to say you are covered, you will have access? What is the basis for eligibility? Can you tell me? First principle, very widespread around the world.
What do you mean? In a given population?
In a given population.
Citizenship.
Citizenship is one, for sure.
Not in Argentina.
So what is there in Argentina if it's not citizenship? Because it's not in most countries in the world.
Universal. Okay.
Right, no, but if it's not this, what other principles instead of citizenship?
What I mean is that in Argentina, even if you're not a citizen, you can show up at a hospital and you
okay.
get coverage.
Yeah,
It's even more wide.
brother, okay. We're using citizenship in the broad sense, not legally, people who can vote. It typically includes also residents, even if they're not legally citizens. But if it's not citizenship in the narrow or broad sense, what other principles have there been?
Income level. Income level.
Income level, purchasing power, right? That's actually the most common basis for eligibility. The state, says you can purchase it, you have access to it. You're eligible if you have the money to buy it. So purchasing power, I'm gonna put it here as one, not because it's the most important. It's actually a principle we would like to see banned, but it's very purchasing power. This is actually a very common principle, and it's expressed in out-of-pocket payment. You become entitled to a service or eligible because you can pay for that, okay? It's the typical situation where you go to a hospital and the first procedure is a wallet biopsy, right? And then if you have power, if the procedure is positive, then you are eligible. Jeff, you were going to? Age as an eligibility principle can be combined with others. So it's a very good point. You can have modified or restricted criteria of this. Again, we're talking about citizenship, meaning you don't distinguish by income level or geography. But if there's an attribute, and that's exactly how Medicare came about. So restricted definitions would include, for example, age-related eligibility. And that's exactly what happened with Medicare initially. Then others had been added. It was everyone, but you have to be over a certain age. A great point. Christine.
What about profession? Because a lot of people get healthcare kind of directly related to their profession,
Right.
or are covered through that way.
So these historically, these are variants of what one can call socially perceived priority. And most I phrase this very carefully because I don't think any group has priority. So it's socially perceived or defined or imposed. Most employment-based forms of insurance, whether it's social insurance, which is the more common, or private insurance, but it's employment-based, is because we're saying, these people, because they're our workers, they're productive, whatever, they have priority. And in fact, most health insurance historically started with an idea of socially perceived priority. You will typically find out in social insurance for the armed forces, they are fighting, they have priority. For the employed workforce and civil servants, of course, it's very convenient if you write the rules to write them in your own favor, right? So most countries, civil servants have more generous benefit packages than the rest, okay, understandably. And how is it legitimized? We are the collective mediator. We are socially priority. We have social priority. So very, very pervasive principle for eligibility. By the way, you could say that age is that. I tend to put it as limited citizenship because, Medicare, it doesn't matter, what other thing, if you were previously employed, if you were previously, so, and it is the one case, by the way, that I know where it's found. And then there's one more principle that we're missing here, very important. Poverty, exactly. So poverty also historically has been a very important principle for defining. And here in the States, Medicaid was born like that, but across the world you have, public assistance or social assistance. Even the word assistance means we're going to help you. It's not that you are a consumer with money, it's not that you are a worker with priority, and it's certainly not that you're a citizen with rights. It's because you're poor. We're going to help you, and here are some services for the poor. Of course, historically we know that services for the poor end up being poor services, because they don't have money, power, then, or rights, then those services tend to be the least quality when they are segregated for the poor. And we'll talk a lot about this when in the almost last session when we talk about health reform. So these are our historical 4 principles. And so lastly, because we're out of time, the choice of principle reflects social values. And this is why we wanted to include in this session this whole question about values. Because very often a lot of the discussion on the health system looks like a very technocratic discussion. And we do know, that certain forms of payment and financing and organizing the delivery. But I believe that any health policy must start with an ethical deliberation. And we're going to get at the end, into this debate. So so that you can start thinking of how to frame. What's the fundamental choice here in terms of values, in terms of how we see access to health services? Let's even narrow it to health care. There's a fundamental tension here between what sort of broad conceptions about the nature of healthcare. Yes.
So health is a social right?
So health as a right, and that's right. As opposed to, Mary?
That's what I was gonna say, a social right for everyone.
For everyone, a universal right, okay? Now, when we define eligibility on purchasing power, what are we saying? Right? It's a market good. And therefore, the key distinction that societies need to agree on is, are we going to think of healthcare as one more element of the reward system? Right? Just, like you buy cars or whatever, it's part of the reward system. Or are we going to think about it as a condition so that the rest of the reward system is considered fair? And a lot of most countries, and certainly most industrialized countries, long ago opted for the second answer. It's not in itself part of the reward system, because it is a condition. Because think about it, except for hypochondriacs, there's no inherent satisfaction or utility, to use the economist term, in consuming health services, right? If you're a hypochondriac, yes, but other than that, it's because you're doing that for something else. And the something else is that you want to have the capability to, then enjoy the rest of life, right? In the United States, that fundamental question has not been answered as a social consensus. And some people will tell you, it's fine, there's a need for transportation. Some people have Rolls-Royce and other people have bicycles, but they all get transportation. It's no different with healthcare. People at the other end say, no, this is very different. This is like primary education. This country did agree long ago that basic education, now going through year 12, K to 12, is not part of the reward system. It's a condition so that the rest of the rewards, the distribution of the rest of the rewards is considered fair, okay? Because if you're a child, you want to start the race for life from the same start line, right? And that's the whole idea of equality of opportunity. And Here, no question, public education, there you may improvement, but there's no, that was a fundamental agreement. Most other countries, including poor countries, but certainly all of the other industrialized countries, said the same thing for access to healthcare, but not the U.S. And I think a lot of why this is such a complex political issue is because there's no fundamental agreement on this big question. So to end, because we need to move on to the more technical aspects, there is a paper there in your readings where we try to develop an explicit framework. The case is the health reform in Mexico, where we explicitly, I mean, this was, and it was not us saying that. There was a very several month consultative process, and we boiled it down to 5 values, all of them explicitly starting from the point of view that the basis of eligibility had to be universal citizenship, not restricted by age or anything else, universal. And then that got translated into 5 values, and you have that. I'm not going to explain them. Social inclusion, you include everyone. Equal opportunity, it's exactly the question we were talking about. Financial justice has to do with that goal. Financial justice means you contribute to the system according to your economic capacity and receive services according to your needs, your health needs, right, as we define them. Out of pocket is exactly the opposite, right? You contribute according to your level of health needs. If the sickest pays more, and you receive according to your purchasing power. That's that's the opposite principle when you have a system mostly funded by out of pocket.